I yelled at people. I thought you were supposed to break them down. I thought you were supposed to just reduce them, tear their walls apart.
We know that the system is fucked. We just no longer were willing to sit and say, great, the system's broken. We were like, we're gonna start fucking thinking about this.
The facility should not be garbage. I shouldn't walk in there and feel dirty just walking into this place, or feel like something moist, around me. It doesn't need to be, massage every day, like a spa experience. What I do need to do is I need to be able to walk in and feel valued right away.
We discussed this morning. It's care. You're creating care for people. Even if that family never comes into treatment, you're softening their amygdala response, right? You're regulating their nervous system. That's care. That is care. And to do the opposite is just so counterproductive.
Talk a little bit about like monetizing chaos.
Yeah. So that's part of the structure. And probably most of the people that do it, that perpetuate that, don't know that. Part of the structure, what you're taught is to say to people, oh yeah, it's 30 days. 30 days, you'll be fine. 30 days, no problem. You can bring your phone, you can bring your computer, right? That's chaos, because what happens is that admissions unit knows when that person arrives that the people on site are going to say, you can't have your computer, you can't have your television. It's not 30 days, it's 45. Right? That's monetizing chaos, right? That's making it part of your structure, as opposed to our intention here, our deep intention here is to be completely transparent to people, to say, this is the length of time. Sometimes things can derail that, but this is the length of stay. Here's the end goal. Here are the end points within that pathway of care. And we're being very candid about it. And if something's going to change in that, we're also going to be very direct and very candid and give you reasons why that is, not just hide it inside clinical complexity. We can't really talk to you about that. We're the clinicians and we really understand the complexity of the case. Again, that's monetizing that sort of chaos and obfuscation in some ways, maybe.
Okay, but you've seen hundreds of these companies.
Yeah.
So do you think it's because they want to monetize that? Or do you think it's because there's call it laziness factor, that creating simplicity is actually really challenging. It's really hard to do. And they don't want to take that next extra step to create the simplicity, because that requires a lot of energy. And then when you do that, you also kind of put yourself in a little bit of a bind now. Like, hey, you actually got to play by the rules that you just set up. And so like some of your profit motive is lost, and some of the other, there's some new expenses that kind of fall in line, right? Like, so how much of it is that they want to monetize versus that they just don't want to take the extra steps to make it simple?
Yeah, but you see, I go back and think that choice not to take those extra steps is an intentional choice. Like, that's the structure of how we work, right? And I don't even know it. And maybe it's something completely subconscious, although it's driven down from the top. Like, we don't do that. Like, we don't give those explanations. We don't guarantee people their length of stay and their time in treatment. We don't do that. And so whether it's somewhere at the top, I want to think somebody with enough intelligence to understand organizational culture and structure has thought, like, this is the way to do it. Because, again, I'm not going to name a name, but I know of recent, somebody said to me that there's like a sheet and an algorithm in their admissions unit that triggers if the person's insurance policy is a high-paying insurance policy, and then that person is prioritized.
See, I just have like more benevolence, I guess, because I think
I'm more benevolent.
Yeah, I just think that sometimes people will just they intentionally want to create chaos. They intentionally want to, whatever. I just think that people sometimes are lazy, or they just don't know any better. They don't know, the leadership didn't take the time to think through what the structure needs to be ahead of time. And I should probably blame them more, but I don't, I guess.
Yeah, again, my experience at an executive level in a private for-profit was that when I said, as the executive director and vice president of compliance, when I said, I want to see the budget for utilization review so I can tell you whether I can build it here, I was told, no, you don't get to see the budgets. No, you work towards activity. You don't get to see the budgets.
Yeah. Well, and it brings up such an interesting dialogue around transparency, right? Which is, you talk about the idea of the genius really exists in simplicity, right? So if we can't explain the topic really to my 5-year-old daughter, right, then do we actually know it? And I think the answer is no, right? We can't break down the concepts that simply, but it's also that like transparency in behavioral health has been something that I don't know where you go for transparent outcomes, transparent financial performance, transparent compliance, whatever surveys, right? Like all of that, like, and done in a public way to establish trust, right? Transparency to me is the foundation of trust from a business. And I was sharing the idea earlier about how we haven't seen it really done in behavioral health, but I think it was Campbell's or somebody like that had like a chicken soup ad. And what they did was it was the chicken soup can and it was the price, right? And what they did was they A/B tested that versus putting on the ingredients. So chicken, broccoli,
I don't know where you had chicken soup in your
potato.
life, but
So maybe we'll
Campbell's celery, onions, potato, chicken noodles.
Here we go. But they broke it down and put the price that it cost them to put it in the can of soup. And then they put their profit margin, 15% profit margin in the price. And they said the ad exploded, right? So the case study on that is you say, here's a thing and here's the cost of it. And there's, all right, there's a little bit of trust in that versus saying, here's actually what it costs us to deliver that product. And here's how much we make on it. And it exploded sales, right? So like other industries have used this to establish relationships and bonds and trust in a product or a service for so long. Yeah, behavioral health, everything has been so secretive for so long, as you mentioned. We only understand the complexities and it's really hard to understand. And in a sense, it's really condescending, to say that like people can't actually handle being able to see what happens behind the curtain.
And we hide it. I think we hide it behind like a clinical nuance, right? Like this is a specialized thing. I think the difference with soup is that the reality is that when I go to buy Campbell's soup, like I know what the product is. I know exactly what I'm going to get. I don't even need somebody to explain it because I know exactly what it is. The problem, I guess, then upstream here is people don't actually know what behavioral health care is. And the offering of products and the offering of this is a good product is kind of really, there is no, there's supposed to be a standard. And yet we know that lots of people slide by in standards. And some of that standard is state by state. So here we are in Colorado with very strong and solid standards in the VHA. And we have worked in other states. I could name some others, but New Jersey, very strict standards, right? Wisconsin, strict standards, right? California, not so strict.
Not so much.
Not so strict.
Yeah. But it comes down to also, marketing, right? We've like the transparency in marketing in this industry, right? It's like so many people have been sold the idea that it's the responsibility of a marketing department or a sales department to basically sell you the idea of hope, but also to sell you the idea that we have the solution. And it's back to expectations, right? Which is somewhat of what I was taking from your initial dialogue around this is like, how do we actually set clear expectations on the front end for people and say like, we don't have an answer. However, we've structured an environment of care where the answer can be discoverable, right? And to support and bring that out in you or your loved one, or whatever it is. But that's completely counterintuitive to a lot of how marketing is done in the industry. So again, back to admissions departments and what they're sold to tell and what billing departments are so, right? All of this is how do we also shift the structure of how we even talk about what we do externally to people in a way that is actually saying like, you can see all of it. Like we will share all of it with you and we're not going to be here to try and sell you some idea when your nervous system is completely out of whack because your loved one is in a real state of crisis. And we're going to capitalize on that moment just to bring you in, just because we can make money, monetization of chaos in a different form. But again, just this idea of transparency here, I think is something that from day one, we've all really looked at. It's like, we literally want to be front and center with everything that we do out in the public about how we're succeeding, where we're not succeeding, where we're doing really well, where we're not doing so well. So like expectations and transparency, it just fundamentally has been a part of what we have built for now over 2 years, leading into, our launch coming up.
So I think of kind of two different paradigms here. One is there's the education paradigm, and then we're just like, as a society, not educated around this stuff. Like, you go to home ec in high school and you put on the beer goggles and it's like, whoa, what's going on here? And that's really the only education you get on this stuff. Like, you don't know what detox is versus ASAM 3.5 and partial hospitalization. Nobody knows what that stuff is. So we rely on people out there who are really smart and go and travel the globe and make sure that they understand who's providing good care, and then they can help us. Those are these consultants that are out there, and they're kind of navigating the way for folks. And then the state does that to a degree also with forensic navigators and other people that are kind of in place to help the majority of society who has no clue what's going on navigate a really complex system with a lot of different moving pieces. So there's that one piece, which is like the lack of education, that I think it opens the door for more of like that kind of monetized chaos, right? And then there's this other part where it's the kind of the need for a family to know that their loved one's going to be okay. So how many times do you get the question when somebody calls in, like, is my boy going to be like sober when he comes out? I'm like, can you guarantee that he's going to be sober? Right. Fucking course not. You can't guarantee somebody's going to be sober, right? So like, then what's the answer? You don't want to have some nebulous, like off the wall kind of overly clinical answer. You want to have something straightforward for them.
And it brings me back to thinking about how the three of us came together, right? It's at this point almost been 2 years. We've announced that we're finally launching Ava Health. Inside Ava Health. Yep, February 9th. But it brings me back to just some of these like fundamental beliefs. So we've talked a little bit about transparency, which we could talk a lot about, but I'd love to just hear from both of you. Like, what did everything you've been through in your career and your life, what did you bring to those moments in the early days when we started to come together and say, there's a real opportunity here to do something really different and not disrupt an industry, but to really do what we believe should have been done all along? So speak a little bit to just like, what are some of those fundamental principles, ideas, thoughts that like brought us together and started to like create this like, whoa, like we can do this. Like we can do this because we all are completely aligned in like what we believe behavioral health care should be.
I'll start. I mean, mine's pretty simple. We're at a conference where I was speaking, and I brought up this point in front of a group of owners of treatment programs that your profit margins should be 15 to 25%. That's the sweet spot, and anything above that really signifies the signals to a buyer. This is like a M&A oriented type of thing, that you're not reinvesting sufficiently back into the organization the right way. And that for me has also been a personal thing, where some of the programs that I had been in were just, I don't know where the money went. It didn't go to us. That was for sure. And so there's like this personal lived experience, as well as knowing that like these organizations do have sufficient cash flows to be able to invest back in. And what does that mean? That means investing in the right staff, making sure that they're coming to work taken care of so that they can take care of their patients. It means the facilities. The facilities should not be garbage. I shouldn't walk in there and feel dirty just walking into this place, or feel like something moist, around me. The bed should be clean. I walked into one place, my first day, I walk into my room. There's like, it's a tiny room, and there's 2 bunk beds, which whatever, it's fine. I know you're like anti-bunk bed. Yeah, all right. There's 4 grown men. The guy actually like right beneath me was like 450 pounds. Like a big dude. And so like the 4 grown men in this little room. But I walk into this thing, and there's a bullet hole in the window right there. And I'm just like, okay, where am I? Like, you could have fixed the window. It's just little simple things like that. But even going above and beyond, it doesn't need to be you're getting, this, massage every day, like a spa experience. I don't need to go on like a backcountry guided trail, like snowboarding session, with Jeremy Jones or something like that, although that would be great. But I don't need to do any of that stuff. What I do need to do is I need to be able to walk in and feel valued right away. And I need to have an experience there where I'm eating well, I'm not just eating like processed sugars every single day. I need to have a care team that I know I can trust and feel safe with and secure with. It's the basics, right? And again, that just comes into reinvesting sufficiently back into the organization. So for me, that was the primary thing where I was looking for other folks who felt similarly. But it's not about like just generating these crazy margins. It's actually about generating cash flow so you can pour that back into the client experience. And I found that in you guys.
Mm.
And I clearly, by the way, and you were there, I did not find it in that room. I had a line like 8 people deep waiting there to debate me on why I was so, I mean, like, how could you say that? Like, I can only make 25%. And it's just like, yeah, okay, this is the industry that we work in. We're going to judge it, but like, I disagree. And when it's time for me to start something with the right partners, you guys, that's not what we're going to do.
Yeah, there's plenty of money to be made at 15 to 25% margins.
Right?
Yep.
Why do you need 35?
Well, you do from an outside capital perspective, which is maybe another dialogue, right? Well, like if you have outside investors and all of that, which we don't. So we don't have to provide specific IRR return metrics and any of that to any outside investors, right?
That's
so
a good point.
These are all like the considerations of that. But I think if the capital is structured correctly, 15 to 25% margins is plenty of money to go around and to really take care of the people that have invested themselves into helping you build something special. So yeah, capital is definitely a part of a dialogue I think we should get into at some point. Maybe we will later this week.
Go.
Fundamentally.
I mean, fundamentally, again, not to reiterate what I spoke about on episode 4 of Brokenish.
Brokenish, episode 4. Bam.
I'll say it just in a slightly different way. You know, what just came to my mind as I was thinking, you know, there's a really interesting study out about entitlement in class, right? And not like not the bad entitlement, like the sense of self. And they looked at it in terms of medical engagement, right? What they found was that working class families, the children never questioned the doctor and rarely did the parents question the doctor. But in middle class families, children had a sense of entitlement and they would say, well, why are you doing that? Even like 8, 9, 10-year-olds would say to the doctor, why are you doing that? What is this? Why are you doing this? And I thought, like, that's a really interesting piece because what we generally provide in sort of mainstream substance abuse care is like, it's underpinned in some respect by like, shut up and let us do what we need to do to you, right? Stop getting in the way of your care, right? And everything you think and everything you want to do, everything you're about, it gets in the way of your care. So you just need to listen and do what we say, right? Now, we would never tolerate that from our physician. And we know that in the medical field right now, one of the challenges the physicians say is our patients are far more educated now than ever. And so they come in like saying like, well, I want to talk about these 4 medicines that I've seen out on, right? You know? And so, and again, you know, I was looking for a place for that. And it's right there, you know, it's Bill Miller, Steve Rolnick. And they said things like, very simple things like, we needed to stop talking. We needed to listen to our clients. Maybe that was what was most important. And they started to say things like, we recognize that these people know what they need to do. They know what they need to do. We just have to listen and give them the pathway to do it. Like they have like amazing resilience and amazing like willpower, amazing willpower. Don't tell me people that have use disorders don't have willpower. They're like, to do that is to sustain a substance using lifestyle is just crazy. Like it's so hard to do, you know? And so I needed to find a model though, right? You know, for me, it's all about the granularity and the structure because underneath like everything I do, if I have that, then I can leap from it, right? So that's what it was. And I started to do some of that stuff. I started to, you know, just ask open questions and listen to people's responses. And it was fabulous, except for the other side of the aisle, which was providers and peers who weren't accepting that kind of like approach, which is that, listen, the expert's sitting right across from you. They're in the chair, they're in the client's chair, they're telling you what they need to do. There was see, if I say there was resistance, then it's me in that model. I'm the one who's forcing that resistance. But and every once in a while, that's kind of good to do. And so I know when I came into this setting, like I knew immediately that you were yes, like all those concepts, the client's the expert on the client, listen, the client has a pathway, I knew that this was a safe venue for that. And so that's really what spurred me on. Again, I want to tell you something. I went back today to read some stuff. Sampson's definition of recovery has nothing to do with apps. It doesn't even mention drug use, doesn't mention substance use, doesn't mention abstinence, doesn't mention anything. It talks about things like living a self-directed life, right? Being the best that you can be for that time. It's not what I want for you. It's what do you want? Let me help you get there, right? So I think, again, if we're circling back, and for me, again, I say all of that was necessary to get me to here in my life. And I've been working on that for many, many years, because there were many years where I told clients, shut up. You don't know what you're talking about. Just I said, take the cotton wool out of your ears and stick it in your mouth, right? And now I'm just the cotton wool banned completely. Not in your ears, not in your mouth, right? And I did all that. I yelled at people. I thought you were supposed to break them down. I thought you were supposed to, just reduce them to just tear their walls apart and reduce them to. I believe that's what you're supposed to do, because that's what people told me you were supposed to do. That's what told me had to happen. And that's not what my pathway was, but other people who were teaching said this is what you need to do, and so that's what I did. And I was burned. I was burned after, I don't know, 25, 28 years of doing this stuff. I was just what is my purpose? I don't know what I'm doing anymore, right?
Yeah.
Yeah.
Well, it's interesting because we haven't spoken to the idea that there's about 65 years of experience professionally in the space between the three of us. And, I share from my perspective of, again, coming from very much the client doesn't know what they need, so we have to tell them, and if the client's resistant, we have to break through the resistance, right? And
the fool, the joke, the fool for us was we're doing it with love, man.
Oh yeah,
I care about you so much, man. I care about you,
right? So I'm going to kind of shame you and try to break you down, and so just the transformations in thought. To me, it comes back to finally being in a place, and it's probably some maturity, experience, expertise, growth, right? To beginning to critically think about behavioral health care for myself, right? And say I was taught these things, and I understand these models of care and understand this, and I've seen some of what works and a lot of what doesn't. But what if I just take a step back and start to think about what resonates and what aligns and what feels right in so many ways. And that to me is such an important piece. Is that ability that we had because we were all consultants at the time, right? We had built things before. We were in kind of this phase of trying to help other people build some of their dreams, and using our experience and expertise and having done it, but also, having helped a lot of other companies do it. For me, it allowed this opportunity to just step back. And you mentioned being able to see under the hood of a lot of companies, and just saying what did I learn? What worked well? What didn't work well? What have these companies done well, struggled with, all of this, right? And it's the culmination of that, right? And this kind of thinking critically about behavioral health care and saying, what if there was just a whiteboard we could create based on all that we know? What could we create, right? And it comes back to some of these other things about accessibility and healthcare equity. I always use that because that was your term, right? It's I used accessibility, but the idea of people should not only be able to access high quality care that provides what they need and takes care of them and values them and provides really comprehensive care just because they have money. So let's critically think about how could you tackle that? How could you increase access to quality care through that? How can you blend in, right? Reinvesting into culture, into people, and creating a culture and a value of that, and treating clients and families that walk through the door as the experts on themselves, right? And so for me, it's those moments of time, right, 2 years ago, of all of that coming together was really a representation, I think, in so many ways of what has been a bit broken-ish about our healthcare system, and, radical hospitality, right? We are literally caring for somebody the moment that they come in contact with a website or pick up the phone or any of this or walk through the door, and like the hospitality element of healthcare has gone out the window, right? And so it's like, to me, it was taking all of these things and then saying, like, we have the audacity here and the expertise to say, like, we want to figure out a way to do this differently, and not in a way that is like disruptive, but actually like, what should behavioral healthcare have been from the beginning? And so it makes me think about, like, from a family's perspective, because we've talked a lot about just kind of like the underpinnings of how we got here, but from like family perspective, like, a lot of this that we've talked about are a lot of the fears that like a family, if they called us and they had a loved one struggling or suffering and saying like, I need help right now. There's so many fears that families bring to the table and individuals bring to the table. And I just want to like dive into that a little bit.
Yeah. So I was doing some writing, and something really resonated with me. Families aren't afraid of cost, right? That's not really what they're afraid of. They're afraid of having no control over what's going on, because they're already sitting in a set where it looks like they're out of control. I mean, to have your child, like, listen, there's an old saying, I forget who says it, I'll have to get the reference. It says something like, you're only ever as happy as your most unhappy child. And that is true. Like, that is really true. Of my two sons, if one's doing great, but the other one's not doing well, then I'm not doing well, and that's just the way it is. So I think that's really what it's about. For families, it means it's not really an issue to pay. That's not it. It's that along that, there are these ambiguous answers. They're not clear touch points when decisions get made. They're not given clear time frames. Like, all of that stuff is all about control. Like, they want some control. And, our nervous systems, when we're out of control, are just firing all over the place. And so again, like, I also wanted to go back and say, like, from a culture, the thing that I know is different about this organization is that leadership's not insulated from all of that other stuff. So if something goes wrong, right? If there's a poor outcome with a client, right? Again, I have worked in organizations where we come down hard on the frontline staff instead of like looking upstream and saying like, what was this about? What do we need to fix here? Right. Whereas, and then again, in leadership, look, I was part of that leadership that sat in the back office and said, that's those evening techs, man. We got to work on them. We got to beat them into shape. Like, no, it had to do with all, because that was the culture. The culture was, we are insulated from these problems, right? We make decisions from the ivory tower, and then people have to go out and do it. We don't, again, we were a relatively ethical organization, and we still lived in that stuff, So again, but you see, I can roll it all back to saying like, listen to what people are asking for, right? And don't say, well, you don't need to know that, or we don't really know because your son's case is very complex clinically. Bullshit. This is what we do know. At this period of time, we are going to review and see what's going on. And I'll tell you the flip side as well. Again, just about monetizing chaos. Like, I know this organization, I was doing this in San Diego before I came here, which was that there was always this part about like how we want to engage the person who's making the phone call. However, there's also like an efficiency piece, right? So we don't want to spend 20 minutes in engagement. Like, after I've taught the staff, like, this is how you really do in like open questions and engagement, make them feel affirmed. We don't want to do that for 20 minutes and then discover there is absolutely no funding stream for them to come into care. So we said, well, let's be efficient. Let's affirm for like 5 minutes. Like, let's just spend the first 5 minutes saying to them, this is great that you called. And a lot of times it was a family. And we would say things like, we love the fact it's so clear you really care about your loved one, your husband, your brother, him. And then we would say, like, we have to ask you a difficult question, which is, what source of income do you have in order to pay for treatment? Do you have insurance? Do you have Medi-Cal? What is it? And if they would say Medi-Cal, and at that time we were not certified for Medi-Cal, we would say, I understand, we can't offer you that care, but right now we're going to send you a sheet, and it's going to have all your options for those insurance, Medi-Cal, private pay, all that stuff. That's going to be your option. And generally the response we got was, no one's ever done that for us before, ever. Right? So again, it's that notion that we're not all things to all people. And I know that you've worked in organizations where the family may have said, like, we really want this, and they've been convinced otherwise that that's not what they want and that they should send their loved one. So again, for me, it's we're really clear, like, this is what we're going to do. This is how we do it. We're very clear. We're very clear what we believe. And if the family says, well, no, this is what we want, we will say, we'll get you there. Okay. Yeah. To me, that is like, that's integrity. That's integrity lining up with what I do.
I think the first call, whatever, the first treatment experience that you're helping your family member get into, that's super important, because you make all these calls and you hit dead ends over and over. And you don't know what you're calling into either, right? Like, you might just be calling a place that you just Google rehab near me, unless you can afford, again, like a interventionalist or a consultant or something like that that's going to help you navigate it all. Rehab near me. Is it a PHP or IOP? Is it RTC? You have no idea what it is.
What IOP is.
Yeah. So you call in and it's like you're just hitting brick wall after brick wall, because really the only thing that matters is, like, what's your SEO look like? Is your SEO bringing you to the top? And are you playing Google My Maps or Google My Business, like on maps, like, well enough? Like, do you have, like, your satellites set up in the right parts of the city so you're getting picked up, like, higher in the maps and whatever, all that stuff? Are you spending enough money on your ads budget?
Well, I saw a presentation about, I think 2 or 3 years ago, I think at the Cape Cod Symposium, and it was a moderation based kind of program, right? So they would work with people who came in and said, like, we want to figure out how to drink appropriately, right? And they had some structure, and again, one of their structures was, but for the first 2 months you got to be abstinent because it's easier, right? It's really easier. But there was a really cool statistic that they showed, which is like something like 25% of the people that are funneled into, only about 25% of the people that are funneled into residential detoxification really need that. However, again, it's that if I am a hammer, then everything is a nail. So if the bulk of my product and the way I make revenue is detox and residential, everybody needs it. Everybody needs it.
And actually, that's where I was going to go next. So, like, and what's so interesting about it is, that, going back to the first question, what really brought us together, we all had that same belief of full continuum of care with no wrong door, which is a radical idea right now.
Yes.
Why is it radical? I mean, again, like, I'm only coming at it from one person's angle, but my opinion as to why it's a radical idea is because private equity doesn't want to buy that. Private equity doesn't like the full continuum model, because you have certain levels of care that are really expensive to administer and other levels of care that are really profitable. So why not just go after those levels of care that are profitable? And hence you see all these groups that are popping up all over the place that just offer those profitable ones, and those really difficult ones to administer that don't generate all the margin. Why'd they go away? Well, it's because private equity doesn't want to buy them. And so you guys were, like, totally aligned and just like, no, full continuum of care, no wrong door. So when someone calls us, again, yeah, you're right, we're not everything to everyone, but we do have the full continuum of care.
We do, and that also allows us to engage with people in what they want, right? Because again, I just want to go back and say, like, the model is not like, again, an MI model, that kind of model where we just really more about the values of it. It's not a passive model, right? It's just that we're not telling people what to do because we think it. We can tell people what to do. We can give them information, but it's so much better when it's based on their experience, right? So instead of saying, you have to go to detox, inpatient, residential, up in the mountains for 30 days. Okay? And the bandwidth is like, okay, some days you may be able to call out, but some days you may not, right? And if you want to leave, like, you can't leave because there's nowhere to go. You're 40 minutes driving from, like, real civilization. And again, the full continuum allows you to say to somebody, sure, you want to start at IOP? Okay, yeah. Sure. You want to start in outpatient therapy? Okay. And even then, the question becomes, in our outpatient model, whether our therapists feel comfortable about seeing somebody who is continuing to use. Again, there are boundaries. So I may say to the client, listen, I know you smoke cannabis. Like, I don't want to, like, don't blow it in the parking lot before you come in for this session, okay? When you get home tonight, no problem, right? And I'm willing to continue to see him. Am I willing to continue to see an intermittent meth user in an outpatient counseling setting? Maybe, until the time when he says, "Oh, wow," and I say, I'm a little worried about you. I'm not cutting you off. I'm worried about you. Like, your meth use is it's escalating a little bit. Why though? Why do I know that? Because there's no tug of war, push and pull, right? We're not batting heads against each other. I'm just holding the space for that client. The client's going to tell me what's going on because they know I'm not going to be like, you're going to fucking rehab today. You're going to rehab. I'm calling the interventionist and you're going today. Okay? It's not going to happen.
Well, and like I think Minnesota is the only state left that requires Rule 32 assessors. Am I right about that? Am I wrong?
Oh, and I'm not what you're talking about.
You drop them there.
All right, Rule 32 assessors. That's like an intake. Like it's basically somebody in admissions that has to like affirm that you're meeting the right criteria to be like admitted into a certain level of care per ASAM.
Okay.
I actually don't think they're even required in Minnesota anymore, but a couple of years ago they still were. And those are the only state left where you were required to have a Rule 32 assessor. I at first like thought, man, that doesn't make any sense. We should have that in all states actually. Like you should be required to have somebody's name on the line saying Jimmy meets the criteria for IOP, not for ASAM 3.5 or whatever. And then we started having these conversations and I realized you're right. Back to your point, there needs to be some latitude. Maybe he's not ready for ASAM 3.5, even though he meets that criteria, or even detox. Maybe it is appropriate to start him at a lower level of care and allow him to step up.
Because then the conversation isn't, this is what I think. The conversation is, David, we tried IOP, right? And it worked for a little bit. And then you returned to use. And then you came back and you stayed sober now like 35 days. And then you returned to use. And then you came back, you stayed sober like 14 days. Like, David, like it's getting shorter and shorter between the periods of time. Like, and then I asked the question, what else would need to happen for you to decide maybe like a little higher experience would be more effective? What else needs to happen for you?
And I can answer that question knowing that, like, man, I'm safe with you. Like, and I have housing. I'm fed. I'm taking, I'm taken care of here. Like, I can answer that question honestly, as opposed to being on a phone call where I'm like scared shitless. I don't know what I'm gonna do tomorrow. Like, and I'm trying to answer this question and just I'm in survival mode. My amygdala is fucking firing at this point, right? So,
well. And look, I'm going to totally cut you guys off because I want to talk too. There's plenty of times to be behind the curtain inside Ava Health. But as I'm listening to you both talk, part of it does come back to the way that an organization is structured, right? So like, certain decisions have to be made when we have to look at financial performance in a certain way, right? We have to get people into certain levels of care to meet certain metrics, to meet certain revenue targets, to meet this, and provide certain returns that, right? A lot of what we see and what we have seen is the prioritization of things like readmissions, things like getting people in at all costs, right? Being very program driven instead of individual driven, right? Like there's all of these things. And like, I can say it here, right? Which is like the people at this table are the ones that own this company, right? There's no other money behind this, right? The decisions that get made today and tomorrow and next week and next month and next year will be with the three people here, as well as the stewards of our culture, the people that we've brought in to help us, right? All of our staff, our management, our directors, right? And having this culture where there's no ivory towers, there's all of this. And like, so it comes back to like, we can do things that a lot of other programs can't because the decisions get made here. So does it work operationally? Does it work financially? Does it match our vision and our values and fundamentally what we believe in terms of care? It does. Great. Those are the decisions we can make, right? Whereas a lot of other people, they're hamstrung. Right? They can't make certain decisions because they have to ask 3 rungs up. They have to, right? They have to maintain a lot of these things. And it is a lot, let's be really clear, it's a lot harder to do what we're doing than to say,
It's much easier to deliver edicts.
this is exactly the structure, this is exactly how we do it, this is exactly who we bring in, this is exactly what we do. It's much easier to do that. It's a lot harder to deliver care the way that you guys are describing, right? We have taken the harder path to say, A, nobody's going to tell us what to do, right? And we did that in a collaborative process with stakeholders with the state of Colorado who believed in this vision and this, right? And funded us, gave us the startup capital to do this. But also it allows us to be individually driven and not program driven. And not to say that here's the exact policy and you must follow this policy. And if you don't, as a staff member, then you're in trouble. Or that you're a client and you can't, if you come in and tell us you used, bam, here's exactly what we do.
You smoked weed last night? You're off to residential.
Correct. Right. Or we can't have you here, so you have to go somewhere for detox for 4 days, even though you smoked cannabis for a night, which doesn't indicate the need for detox, right? Like a lot of the structures that have been set up.
Does it? What are those reimbursements again?
Yeah, exactly. I know that's when you get the Dr. Evil in there, right? Looking at, how do we continue to increase margins like that? But it comes back to like, for me, like, these are the types of conversations that helped build this company and continue to do so because we continue to be able to critically think about what do our communities need? What do our clients need? What do the families need? What do our people need? And we get to make those decisions at tables like this, right? So we become the antithesis of much of the industry, which is program driven. This is exactly the lane you must stay in to be successful here. And if you don't meet that, we are going to call you resistant. We're going to tell your family to stop answering the phone. We're going to tell your family to cut you off. We're going to tell your family to let you hit rock bottom, right? And that is a lot of what has been pushed in the industry. This is a new idea in many ways, even though it's not new. But the idea of saying like the client is the expert, the family is the expert, and we're here to like facilitate and guide. And part of that is how we have been able to structure this to be able to deliver care like that.
Again, it's the 2 things I'll say is, first is, I was thinking which order I wanted to say is, in this organization and in better organization, culture shows up before the products show up, before the services show up. Culture shows up. And so the flip to that is, so like length of stay, payer mix, very important. But what we have are guardrails up so that never dictates care.
Right.
There's always some decision making and there's always a lens to it, but it doesn't dictate care like you described. And again, it just occurred to me in reflection that I think a lot of my retrospective reflection on what those organizations were like now is very clear. They weren't culture driven. They were very policy driven, very procedurally driven. It was interesting because when you were talking about procedure, I thought, but that's not us, because there are, but then I thought, but there are policies, and it is very clear. Like we want people to follow these policies. However, the policies are so integrated into our culture and beliefs that nobody should find anything in a policy here that is incongruent to what we fundamentally believe. And if they do, we are changing the policy.
Right.
Oh my God, we're changing the policy.
So I think like I always joke about, we're idiots actually, because we're doing the harder thing to ultimately make less money, but that's actually not true. And also like at the beginning of this, I was saying like, I'm not benevolent, I am too benevolent to like other leadership groups because they don't know what they don't know. And so I'm not going to like blame them for that. And that's not true either. I do all the time. So like, and you brought up some things that just like that hit the nail right on the head for me and just gets me all fired up here and that, like readmissions, for example, like, these people like they prioritize readmissions as a metric that ultimately is going to drive profitability for them.
Completely.
which is so stupid because we already know that as we move as an industry more into value-based care contracts, that is a metric that's going to be looked at, and that can materially affect capitation. And even in the world that we live in right now, which is just the reverberations of VBC within the fee-for-service frameworks, we already know that when you come back for contract renegotiations, that's something that payers are looking at. So we actually are playing not the junior varsity bullshit game of like, let's prioritize readmissions. We're playing this varsity longer game of saying, hey, in 5-10 years from now, we want to be the organization that's really moving and shaking things. Readmissions is one thing. There's like several others, but like you have something to say right there too, so I'm going to pass it over to you.
No, I was just thinking, and there are some examples. There's a hospital in New Jersey that's, is in a value-based contract, and basically if they have a readmission within 30 days from the psych emergency, they eat that. They pay the cost of that length of that stay, which is, thousands and thousands of dollars. You said something, and I forgot what it was.
Well, then let me go to the other one I was thinking of too when you're talking about that, which is like pushing decision making down to the actual frontline staff, the people who are in the trenches of the warfare day in, day out with the patients, actually providing the care. Like, it's so much easier to provide the edict for everyone and say, this is how it has to be done. It's so much harder to allow them to do that. However, again, this is where like the JV versus the varsity level comes into play. If you're thinking of scale, if you're thinking of, it's not just Mesa County that we want to be in. We ultimately want to move on and be reaching the entire western slip of Colorado. And then we want this model to be serving all 50 states ultimately. Then the question is, how do we scale that efficiently? How do we do that the right way? And I believe that you mentioned culture precedes, I forget how you said, but it was something like culture precedes programming.
Like that. It's good. There's a little onomatopoeia there.
That was good. Yeah.
Alliteration, like that.
Well, it's similarly like the decision-making process that's pushed to the people who are actually providing care starting from day one. That precedes how we do things when we're at scale, when we're only here at Mesa County. We can work out the kinks, figure out how to do it the right way. Yes, it's harder. Yes, it costs more money trying to figure out the tech integrations so that people are not only able to make the decisions in real time, but have the tools at their disposal to keep themselves accountable, to know what the metrics are that they need to make those decisions against are and make those decisions the right way. So that is important, but it's hard to do. It does cost more money, but thinking long term, it's the right thing to do from day one. And even if we were only going to stay in Mesa County, it still is the right thing to do here.
Right.
It's just, I'm just admitting that like it's really fucking hard to do and it costs more money. And so we probably wouldn't have done it. I mean, I hope that we would have, but we might not have done it if we weren't thinking of scale in mind. So I'm just going to like take ourselves off the hook there and not like make ourselves out to be like,
yeah, great. I mean, again, those programs that have, and I'm not saying all of them, but there are many, many programs that have held tight to like, this is the way we do it. And they're shuttering, they're closing facilities without naming. One went from, I think, 15 to or 20. The plan was 29 this year, and they're down to 7, something like that. Again, we know the largest provider in the world for behavioral health is shuttering facilities. Again, because like people don't fit into cookie cutters, right? This is like we're dealing with humans. Like that's it. We can't. Outcomes aren't predictable. Sometimes they're just not predictable, and sometimes people do amazing things that we look at the client and go, no way. We'll try again. No way, and like, again, people are astounding. Their ability to rise up and to be resilient. It's amazing. And anything that we do in an experience of care that blankets that or pushes it down or nullifies it or tries to quiet it it's just really, it's the complete opposite of who we are and what we believe.
Yeah.
That's what I think.
Well, and part of what brings it out in me is there's the accountability piece that you speak to, which, when we talk about transparency and just being front and center with everything, right? Like accountability is literally built in, right? So even when you talk about pushing decisions down to directors, to managers, to frontline staff, right? There's still sophisticated data systems that, right? There's checks and balances, right? It's not like we just like say, oh yeah, it's good. You go do whatever you want, right? But talk about designing for long-term, right? Setting expectations, and doing this all within what I would have said 2.5 years ago is impossible to do because of the way the system is set up. So I can hear people that might be listening to this who are in the industry saying, like, you can't fucking take Medicaid. What are you talking about? Like, you can't take Medicaid and have great culture. You can't take Medicaid and have certain staff to client ratios. You can't take Medicaid and have beautiful facilities, right? The answer to me, and I know us, became, well, why? Like, we became curious about, well, the system exists. So if we know the confines of the system, we know how insurance works, we know how Medicaid works, we know how people become confined by the system they're in. But what if we became really curious about that system? And what if we began to say, why can't you do that? And how could we do that? How could we provide care in this way, right? And like that to me is like such a like fundamentally like just critical piece of everything that we have built to this point is that we continued to ask the questions. So 2.5 years ago, I would have literally looked at either of you and said, there is no way that we could do what we're doing right now. But that would have been really closed-minded because I wasn't asking the next question as to why. Where do I have that information from? Why do I think that's the truth? And so you talk about like building for long-term and all of this, and it just comes back to me to we are doing the hard thing. It's much harder to be accountable. And it's also much harder to work within a very broken-ish system that does dictate in a lot of ways what you can and you cannot do. However, when you have creative thinkers operationally, clinically, financially, you start to go, well, we know what we have to do to meet the regulatory requirements for the state, for the Joint Commission, national accreditation. But what kind of flexibility do we have in there? What else could we do? How could we take the additional profit margin that we do to hire these people, to increase care in this way, to deliver this specific service, to have locally sourced food, right? Instead of processed shit, right? Like that's where like the creativity and what continues to get me fired up is that like that continual curiosity of saying, we know that the system is fucked. We just no longer were willing to sit and say,
Okay, then.
great, the system's broken.
Okay.
We were like, we're gonna start fucking thinking about this. And so, yeah, it's been really hard to do this. And it will continue to be really hard to achieve the things that you described. But if we're here to truly provide a certain standard for behavioral health, then we have to be able to show how the investments we made today produce 5 and 10-year outcomes in every area of what we do. Economic investment into the communities we work in, to the culture and the people and how we care for people and the client outcomes and social determinants of health, right? All of these things. And so I know I just like tangented, if that's even a word. I went on a tangent about it. But like, to me, I sit here and I'm just like continually inspired by each of you about like the curiosity to think about, we know the system that we're within. How do we look at creating solutions from within it? And like that is the difference at Ava Health to me more than anything, is that we have now stewarded that. I just keep stealing your word. We have stewarded that with the people here who now when you talk about pushing decisions down, they go, yeah, why can't we do that? Why can't we do that? I come from systems that tell me I can't do that. Why can't we, right? Mm-hmm. There's such beauty in that. So like I wanted to like frame that a little bit to anyone that's watching and listening is like, we know that the healthcare system is very broken. The three of us just at some point 2 years ago decided to say, yeah, but what? Are we going to sit here and that's going to be the rest of our career? Are we going to look to build legacy? Which I know is like been obviously really important to you and a word you use a lot. But are we going to really take like everything that we have learned to create something that is going to withstand the test of time within the system that we're in? I mean,
again, my experience over the last couple of years, certainly working as a consultant, was it got to the point where it was no longer I was just here to do what you wanted to do. It was like you get to experience some time with Ian. And I began to push some of these ideas forward. And some people rejected them outright. Some people got very turned off to me. And some of the clients actually did it. And lo and behold, like certainly I have one client that from 3 years, like they are successful, right? They just finished their 3rd year. And they now have 2 houses and PHP and IOP and OP, and they're looking for a new location because they're busting at the seams. And again, it's just because they stayed with what their purpose was, in network, contracted, like providing that care, a couple other little small, things, some private pay, no Medicaid yet. I stay in touch with them, haven't gotten them to Medicaid yet, but, and again, that's, and they've softened their position on additional substance use. They softened their position on some other things. And again, it was, they got to the point where it's like, we're going to deal with people that are in front of us. We're going to work with them in front of us. And, so again, she tangented me. So I don't know what the word is, but where it's really to go. Again, I just want to go back and say, again, it's a cultural thing. So it's good. So what's liberating for me in this triumvirate and beyond is like, I'm not afraid. I'm not afraid to say, like, I need help with that. Like, I'm not sure what to do about that, or this isn't working. I don't know what that is. And that's the culture. So it means that I'm always going back and looking at, like, what do I need to learn? What do I need to, like, upstream? That's my latest thing right now is upstream. Like, what's happening upstream? So if our AMA rate's not great, like, we gotta look upstream. We gotta look down. We gotta look at the stream in front of us too. Make sure that, that what we're doing, like, in present is good, but we got to look upstream as well. We're always so in some ways, culture is risk management. Strong culture creates a model where you can look at things and you're not afraid to look and go like that. I don't think that's working. Right? I don't think it works because it's not personal, right? It's not personal. It's like, here's our North Star. This is where we're going to. And I don't think this is serving that, right? I don't think it's doing it. So again, we might find at some point that our stance on, like, we meet you where you're at, right? We really meet you where you're at. Like, that may not be great. Like, for some of our client population, maybe a little bit more gentle guidance might be useful. Or we have to find some other model of care, like a wet house and a wet center.
Man, I went to the one in Minneapolis, and that was not Minneapolis, but in Minnesota, in the suburb of Minneapolis. And it was heartbreaking to see it. And after seeing it, it was like, yeah, why aren't there more of these? Like, because that is the reality. Like, some folks have, for lack of a better way of saying it, kind of given up on the treatment experiment. And I'm not a clinician. I don't know, like, what how to, like, I don't understand people that way. But I did go there, and I did see people who it was a humane way for them to be able to stay warm.
And if it's comprehensive, the first part is comprehensive. There's laundry, there's people there doing benefits, there's some basic medical care available to people. If it's really done well, and I saw this in the UK, and in Nottingham was one of the first ones, like 20 years ago, right? It's connected to more treatment. It's connected to treatment. So when the client who's in the wet center or is in the safer injecting site sees the guy he used to shoot dope with, or she sees the persons he used to drink with, kind of comes in the same entrance but heads down the hallway and says, well, like, oh, where are they going? We say, like, they're in treatment care. Like, you're in care too. Like, we're doing what we can for you, but they wanted to go a different direction. They wanted to stop drinking, so this is the way they're going. Or they don't want to use heroin anymore, so they're heading over that way. They're getting their Suboxone prescription, right? And they got some groups, and there's a therapist and a case manager, like, and like, Bill said it, like, attraction rather than promotion. It's what it was really supposed to be.
For sure.
So the idea of, like, again, saying in an AA room, here's $5, go out and drink and come back when you're ready, is so antithetical to what he said, what he believed in from the very beginning. It's so antithetical. It's just how it's morphed.
Yeah.
Right. And how people have, like, again, like, if we don't know something frequently, we make it up. We fill it in for ourselves. So if I don't have somebody guiding me saying, be still, hold space for the client, be still. But somebody's actually saying, man, you got to get in there. You got to get in there. You got to get it instantly. Got it, right? Then that's what I'm going to do. That's what I'm going to do. Because again, especially in our field, people coming in recovery come in, like, they don't want to go back to that. They have that, they're still moving away from it, and they want people to do well. And that's great. And the terrible reality is, if you've worked here long enough, not everybody does well. Mm-hmm. Not everybody makes it.
But, back to what you're talking about, of just like our our approach towards from coming from a place of curiosity and how can we solve issues that we've seen create brokenness in the industry. I like to look at it from this lens of like, we're not these great, amazing human beings who are like doing all of this like fantastic, like, yeah, right. No, I'm sorry. You're not. And neither am I, and neither are you, and Roman, you definitely aren't. But I'm just throwing the shade. Throwing the shade. Roman's probably the most. But no, I like to kind of look at it through this lens of like, so then why are we doing this, right? Like, what's different about what we're doing here? And it comes back to, once again, it's like these basic tenets of like our capital structure allows us to. Cool. Well, like anyone else could have had that capital structure too, I guess, in theory. So, but then like we all had all this time working in consulting and seeing all these other organizations. We've done our own startups. It's like you mentioned, like people would get like their eye-in time to like kind of like hear some of these thoughts, and some of them executed on them and they actually found great outcomes to it, and others didn't. I know my own experience of working on M&A deals and actually, during due diligence, stepping back and either providing consulting myself, or in some cases, you were even the consultant that came in on one of my deals. Sure. And then guess what happens sometimes? They don't even close all the time, right? Because they're like, oh, everything works better now. I don't need to sell this anymore. And that was like countless times that happened in M&A deals. And frankly, I was like, great. I'm not, making the big paycheck, but like I'm really happy to see that this is actually working well the right way now. And so, again, it's just like we've had so many different experiences seeing behind the curtain of hundreds of organizations in this space, not just in the US, but internationally. What's working, what's not working. And you can't go through that experience and not be shaped by it. Not have your view of like what's the most effective way to do this be shaped by what worked well in that group and what didn't work well in that group, and wondering why, man, they're grabbing on to like 75% of the things that work well and they're still missing out on 25. Why are they not grabbing on those last 25% of the things? And these guys are only doing 25% of the things right, and yet they're still operating. Like, but why? Like, why won't they just listen? And then coming into this position of like finding a capital structure where we don't have to return immediate IRR to anyone, or actually ever, but like especially immediate
or ourselves, to be clear.
Mm-hmm.
We didn't have to invest personally into this deal either.
Yeah, there's not like some return requirement that demands get money back into someone's pocket right away, which gives us the space to be curious, to continue to be curious, but to also come into that place of curiosity with all this experience of seeing what works and what doesn't, with all these other groups. And again, I just don't think that like we're these really special dudes who are, so great and benevolent and wonderful and all that stuff. I just think that like our collective experience, you cannot not be shaped by it. And then when you combine that with not having return requirements, it produces the canvas for something really beautiful. And we've taken advantage of that. And again, like the final part to it is that we talk about, Ian, and your legacy with what you're creating from like a operations and clinical perspective with this. I've never even thought of half the things that you've said. Chris, when you talk about reaching the stakeholders in the communities and serving, I've never even thought about the impact that you've uncovered that like we're actually having with like local fire departments and police, like the culture, and seeing the way you shaped the team and how like they're stepping up to the plate to produce answers and thoughts and being curious themselves to solve things. I've never seen other organizations do it. Like for me, it's this really inspiring opportunity to see the way it could work, and yet I've never actually seen it done.
Till right now, February 9th. We're going to go quick hits because we got to get out of here. What should people expect from leadership before they invest in treatment? Quick hits.
I mean, transparency.
Yeah. That they're accessible. And that when accessible, they don't speak in platitudes, that they're dialed right in so that everything the family or individual heard from the admissions worker, they hear maybe a slight twist on it, but again, they hear it's congruent all the way up to leadership.
I love you both. Ian Gershman, Chief Operating Officer, David Purinton, Chief Financial Officer, Christopher Bennett,
Chief Executive.
well, Chief Executive Officer. Inside Ava Health, right? And Roman, Community Engagement Architect. My man over there, handling business. We're going to keep coming to you guys. Inside Ava Health, this is the place to be. We're going to continue to give everybody behind the scenes access to what these companies, how they run, what's going on, transparency, accountability. After February 9th, we'll start publishing some data, what's going on, where we're succeeding, where we're not doing so well either. And this is who makes the decisions. So honored to be here. I love you both.
Honored as well.
Inside Ava Health. Like, comment, subscribe.
Please smash that like button.
Smash that like button. And we'll see you.
Call us because we're transparent and accessible.
Bam. That's it. See you guys next time.